So, good morning, everybody. The topic for my presentation is seasonal affective disorder, and my moderator is Dr. Ayushi Gera. So, what is seasonal affective disorder? This will be covering today. What causes SAD, its signs and symptoms, the complications, investigations, and various treatment options. First of all, what is seasonal affective disorder or SAD? It's a type of mood disorder which is related to the changes in season. Basically, it is a type of depression that is related to changes in seasons. It begins and ends at about the same time every year as the season comes, and it goes off as the season goes. Usually, it occurs in late fall or winters, and in very few people, it may also occur in summer season. That is called as summer sadness or summer depression. It commonly occurs in areas that experience low sunlight levels. Now, what causes SADS? We basically have three things that is known to cause SAD. First of all, the biological clock of a body, the serotonin levels, and the melatonin levels. So, first of all, how the biological clock of our body affects the formation of the seasonal affective disorder. It basically, we have a circadian rhythm which continues according to the environment changes. So what happens in fall or winters, as the daytime decreases and the nighttime increases, the inner circadian rhythm, there is a phase shift of that rhythm. So that may causes the disturbances in the sleep-wake cycle, and accordingly the mood changes, and that may cause seasonal affective disorder. Next is serotonin level, which also regulates the circadian rhythm, and serotonin levels usually falls during the winter. Third is melatonin levels. As we know that melatonin is secreted by the pineal gland, and its production increases during the dark periods. So in winters, there is increase in the melatonin production, which also affects the sleep-wake cycle, and accordingly, it causes low mood, lethargy, and may cause the seasonal affective disorder to develop. Now the symptoms. Now, SAD may occur as winter blues or winter depression, and also summer blues or summer sadness. So in winter blues, the symptoms are commonly there is increase in appetite, weight gain of the patient feels oversleepy, there is fatigue and irritability. On the contrary, summer sadness present as poor appetite, weight loss, insomnia, agitation, and patients may also feel anxious. What are the risk factors? Family history plays an important role. The positive family history is one of the risk factor. Gender predisposition. It is seen that females are more commonly affected with SAD than males. Younger age, having other mental disorders may also contribute to the development of SAD. Low levels of vitamin D, and people living far away from the equator where they receive low sunlight. Complications. Now, the person may experience the social withdrawal, may go into the substance abuse, may develop other mental disorders such as major depressive disorder, or may have suicidal thoughts or behavioral disturbances. How can we diagnose and evaluate the patient? So first of all, we do physical examination of the patient to exclude any other cause that may cause the depression, any other illness or anything. Then we run some lab tests such as CBC or TFTs to see whether there is any thyroid disturbances in the body or any other thing that may cause the depression. And third of all is psychological evaluation, in which we ask some kind of questions to the patient, such as, so this is a SAD quiz in which we ask these questions, and accordingly we mark them. So questions such as, do your symptoms begin during late autumn or early winter? Do you feel sad during winter days? Or do you lose the sense of enjoyment, and so on? So accordingly, we evaluate the patient whether he or she has developed SAD or not. These are the various treatment options. So we can opt for the psychotherapy, phototherapy or medications are the option. So phototherapy, as you can see in this picture, the patient is being kept under the a special kind of lamp for the phototherapy. For 30 minutes or so every day, and it uses special blue light which simulates the environment of sunlight, so that the person who is receiving low sunlight or living in these kind of areas may get the proper sunlight or light therapy. Then we have psychotherapy or talk therapy, in which the patient can talk to the counselor, can talk its heart out, what happens, what is happening actually, what the patient is feeling. So this kind of sessions can also be beneficial for the patient, and we usually do once per week. Some medications such as antidepressants, selective serotonin reuptake inhibitors, melatonin supplementation, omega-3 fatty acid, and vitamin D supplementation may also be proved beneficial. Now, some measures that can be taken by patient itself, natural sunlight, sitting in the natural sunlight every day, having a healthy environment, some lighty and airy space for work, yoga and meditation, balanced diet, and stress management to reduce the stresses in your life. So these are my references. Thank you.
Good morning, everyone. Myself, Arpit. My moderator is Dr. Arpit. My topic is bulimia nervosa. So, definition: bulimia nervosa is defined by recurrent episodes of binge eating followed by compensatory behaviors, which might include self-induced vomiting, laxative, diuretic, or enema use, intense exercise, fasting, and medication misuse or abuse. So, what is epidemiology? Typical age of onset is since late adolescence to young adulthood. Gender, it is most prevalent in women than men. Approx lifetime prevalence is 2%. Mortality risk, reports of elevated mortality rates are present, but additional research is going on. Etiology. So there are four factors: genetic and biological factors, individuals with family history of bulimia nervosa, mood disorder, substance abuse, or dependence or obesity are at higher risk of developing this syndrome. Developmental factors, the psychological and social stressors of puberty and adolescence put individual at risk for bulimia nervosa. Also, the hormonal changes during this time, especially estrogen levels. Psychological factors and environmental and social factors. DSM-5 diagnostic criteria for bulimia nervosa. A. Recurrent episodes of binge eating. An episode of binge is characterized by following: eating in a discrete period of time. Example, within a 2 hour period. An amount of food that is definitely larger than most people would eat during a similar period of time and under similar consequences. A sense of lack of control over eating during the episode. Example, a feeling that one can't stop eating or control what or how much one is eating. B. Recurrent inappropriate compensatory behaviors in order to prevent weight gain, such as self-induced vomiting. The binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight. The disturbance does not occur exclusively during episodes of anorexia nervosa. So what laboratory workup we have to do for these patients? Complete blood count, electrolytes, blood urea nitrogen, CAT, TSH, p-thyroxine, total protein, and pre-albumin, fasting glucose, amylase, if purging occurs, serum phosphate, ECG, bone mineral density. Medical and physical complications seen in this patient. Weight with normal overweight or obese range. Russell's sign. Calluses on hands from teeth scraping during self-induced vomiting. Gastric distension. Swollen parotid and salivary glands. Elevated serum amylase levels. Erosion of dental enamel. Multiple caries. Hypokalemia, hyponatremia, hypochloremia, alkalosis. Prolonged QT interval. Myocardial toxicity. Oligomenorrhea or amenorrhea. The treatment that can be given is psychotherapy. CBT, cognitive behavioral therapy, is the treatment of choice. Others are IPT, interpersonal therapy, DBT, ICAT. Psychopharmacology. Medication as sole therapy is not recommended, but in adjunction with CBT has a strong evidence base. Fluoxetine SSRI is a medication of choice which can be given in a dose of 20 to 40 mg per day. TCAs, MAO inhibitors, and antileptic agents such as topiramate have also demonstrated efficacy in randomized controlled trials of bulimia nervosa. What are the other eating disorders? Anorexia nervosa. Individuals with this disorder exhibit a persistent and relentless drive for thinness, leading to behaviors that cause weight loss. Binge eating disorders. Individuals with this disorder experience repeated episodes of binge eating. However, these episodes are not followed by compensatory behaviors. Avoidant or restrictive food intake, pica, rumination disorder. Individuals repeatedly regurgitate food and then spit out and rechew and re-swallow it. These are my references. Thank you.
Good morning, everyone. The topic for my presentation is restless leg syndrome, and my moderator is Dr. Neetuna. Introduction. Restless leg syndrome, RLS, is a sensory motor neurological sleep disorder characterized by a desire to move the legs or arm, usually associated with uncomfortable sensations, typically described as creeping, crawling, tingling, burning, or itching. The diagnosis of RLS is based primarily on patient self-report and history. The symptoms are worse when the individual is at rest, and frequent movements of the legs occur in an effort to relieve the uncomfortable sensations. The symptoms are worse in the evening or night, and in some individuals, they occur only in evening or night. The symptoms of RLS can delay sleep onset and awaken the individual from sleep and are associated with chronic insomnia. The diagnostic criteria as per DSM-5, the essential criteria include 5 points. A, an urge to move the legs, usually accompanied by or in response to uncomfortable and unpleasant sensations in the legs, characterized by all of the following. First, the urge to move the legs begins or worsens during period of rest or inactivity. The urge to move the legs is partially or totally relieved by the movement, and the urge is worse in the evening or at night than during the day, or occurs only in evening or at night. Second, the symptoms in criterion A occurs at least 3 times per week and have persisted for at least 3 months. The symptoms in criterion A are accompanied by significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. The symptoms in criterion A are not attributable to any another mental disorder or medical condition like arthritis, leg edema, and are not better explained by a behavioral condition like positional discomfort, habitual foot tapping. And these symptoms are not attributable to physiological effects of a drug abuse or medication. Supportive features. Periodic leg movements in sleep, PLMS, can serve as corroborating evidence for RLS, with up to 90% of individuals diagnosed with RLS demonstrate PLMS when recordings are taken over multiple nights. The PLMS during wakefulness are supportive of an RLS diagnosis. Reports of difficulty initiating and maintaining sleep and of excessive daytime sleepiness may also support the diagnosis of RLS. Additional supportive features include a family history of RLS among the first degree relatives and a reduction in symptoms, at least initially, with dopaminergic treatment. These are the symptoms of RLS: burning, cramping, pain, numbness, itching, tingling, aching, and crawling. And the patient, they describe an unpleasant crawling or creeping sensation in the feet, calves, and thighs. Arms can also be affected occasionally. The symptoms are worse in evening and night. The symptoms are relieved by moving the legs, and the symptoms are worse at rest. Development and course. The onset of RLS typically occurs in second or third decade. Approximately 40% individuals diagnosed during adulthood report have experienced symptoms before 20 years, and 20% have experienced symptoms before 10 years. Prevalence rate increased steadily with age until about 60 years, with symptoms remaining stable or decreasing slightly in older age groups. Familial RLS has a younger age at onset and a slower progressive course. The clinical course of RLS differs by age at onset. When it occurs before age 45, it is often a slow progression of symptoms, while in late onset RLS, rapid progression is typical and aggravating factors are common. Risk and prognostic factors. The predisposing risks are female gender, advancing age, genetic risk variants, and family history of RLS. Precipitating factors are often time limited, such as iron deficiency, with most individuals resuming normal sleep patterns. Genetic risk variants also play a role in RLS secondary to such disorders as uremia, suggesting that individuals with a genetic susceptibility develop RLS in presence of further risk factors. It also has a strong familial component. The pathophysiology of RLS is it is significantly associated with common genetic variants in MEIS1, BTBD9, MAP2K5 on chromosomes 2p, 6p, and 15q respectively. The association of these three variants with RLS has been independently replicated. BTBD9 confers a very large excessive risk. Pathophysiological mechanism also include disturbances in central dopaminergic system and disturbances in iron metabolism. The endogenous opiate system may also be involved. This is a pathophysiology by dopaminergic pathways. And as in Parkinson's, we know that dopaminergic pathways are affected. Therefore, RLS is more likely in patients with Parkinson's disease. Treatment. Primary RLS, symptomatic treatment is done usually required throughout their life. Pramipexole and ropinirole have been the FDA-approved drugs in treating moderate to severe primary RLS. For secondary RLS, we have to treat the underlying conditions like iron deficiency and uremia. The drugs dopamine receptor agonist, which is effective in primary RLS, agot derivatives, bromocriptine and cabergoline, and which have adverse effects such as nausea, headache, nasal congestion, and non-ergot derivatives, ropinirole and pramipexole, which are also the FDA-approved drugs. Dopaminergic drugs, levodopa, which is used in primary RLS, which is effective in reducing symptoms and improving sleep quality and quality of life and reducing the PLMS. The adverse events are minor. Dopa decarboxylase inhibitors, like carbidopa, which is used in combination with the dopaminergic drugs. Anti-epileptics like gabapentin, carbamazepine, and pregabalin are also used. Benzodiazepine, clonazepam, which is probably effective in reducing symptoms and sleep latency in primary RLS when given 1 mg before bedtime. Triazolam, effective in ameliorating sleep efficiency but ineffective in reducing PLMS. Adverse effects are morning sedation, memory dysfunction, daytime somnolence, and muscle weakness. Opioids are also used like oxycodone, which is effective in improving primary RLS symptoms, PLMS, and sleep efficiency on short-term basis. The adverse events are mild sedation and rare nocturnal respiratory disturbances on long-term use. The differential diagnosis for RLS is leg cramps, positional discomfort, arthalgias, myalgias, positional ischemia, leg edema, peripheral neuropathy, and habitual foot tapping. These are my references. Thank you.
Good morning, everyone. My topic is sexual response cycle, and the moderator is Dr. Astha Jain ma'am. In the presentation, we will go through the introduction and the stages of the sexual response cycle. Introduction. Sexual response is a psychophysiological experience. The human sexual response cycle is a four-stage model of physiological response to sexual stimulation, which prepares the body for sexual intercourse. The model was first formulated by William H. Masters and Virginia E. Johnson. It is a leading model of sexual behavior called the EPOR model, which stands for the four stages, that is excitation, plateau, orgasm, and resolution. The first stage is the excitement or the arousal phase. It occurs as a result of physical or mental stimuli. During this time, the body prepares for sexual intercourse. In males, there is vasocongestion, increase in heart rate, blood pressure, muscle tension, and there is skin flushing. There is penile erection, tightening and lifting of the scrotal sac, and elevation of testes. In females, this stage can last for several minutes to hours. The onset of vasocongestion results in enlargement of clitoris, labia majora, there is swelling in vagina, and there is nipple erection. Vaginal wall begins to produce a lubricating fluid. The next is the plateau phase. It is the period of sexual excitation just prior to orgasm. In males, there is increase in size of the penis and the change in color of the skin over it. Corpus glands start secreting fluid which comes out of the tip of the penis called the pre-ejaculate. The urethral sphincter contracts, which is to prevent urine from mixing with semen and to guard against retrograde ejaculation. In females, it is just the continuation of the same changes evident in the excitement phase. The third is the orgasmic phase, which is the conclusion of the plateau phase. It is accompanied by quick cycles of muscle contractions occurring in the lower pelvic muscles. In males, it is in two steps. In the first step, the contractions are in the glands that are vas deferens, seminal vesicle, and prostate, which causes seminal fluid to pool at the base of the penis, called the ejaculate. In the second step, the contractions are in the muscles, in a throbbing manner around urethra to propel out the ejaculate. In females, contractions of pelvis muscles occur around vagina, contractions of uterus and anal sphincter in rhythmic way. There are muscle spasms, increase in heart rate, and blood pressure. The last is the resolution phase, which comes after orgasm and allows the muscles to relax, blood pressure drops down, and the body slows down from the excited stage. In males, there is loss of penile erection as blood flows out. Scrotum and testis returns to normal. There is a general feeling of relaxation. And in males, there is a refractory period in which person is generally incapable of getting another erection. In females, blood that has engorged in areas of the body now flows out, swelling decreases, eventually muscle tension goes away. And in females, there is no refractory period, so they have the ability to orgasm again as long as they have effective stimulation. This is the graphical representation of male sexual response cycle. There are three patterns, A, B, and C. In the pattern A, it goes from excitement to plateau, orgasm, and resolution. In the phase of resolution, refractory period is marked, which is specific for male sexual response cycle. And there are other patterns B and C. In the pattern B, it goes from excitement to plateau and directly resolution. And pattern C goes from excitement. There is very minimal stage of plateau, orgasm, and resolution. This is the representation of female sexual response cycle. In the pattern A, it goes from excitement, plateau, 2 cycles of orgasm, as there is no refractory period, and then resolution. And pattern B and C are same as in the male sexual response. These are the references. Thank you.
Because slightly gets a or this we can give a serum like this, packet like this, or packet isoamides.
Have you seen or seen any patient? No, no any patient. Family, elderly female, ask, stand on my feet in the night. सब लोग बोलते हैं पैर दबाओ. इंडिया में है कि पैर दबाओ शाम को. You take that reference of carbamazepine and valproate, Dralma. That can don't give information, but don't give any unvalidated. That is why we ask for reference. We can only give information which is there in your reference. If you give any information in your presentation, it is not there in the reference. Okay. So there are many other things that start being created. Okay. बहुत पुरानी चीज है. क्या ड्रग ऑफ चॉइस उसमें क्या पढ़ा था? ड्रग ऑफ का चैप्टर पढ़ा था. Why do you need so much? वो काफी लेने के लिए कितनी दवाई आती है? फीवर के लिए पैरासिटामोल के अलावा दूसरा कोई जानते हो? एक तो काफी तो इफेक्टिव होनी चाहिए. मतलब थोड़ी सी 10 दवाई लिखना जरूरी है कि you have to write all the. आयरन का कुछ लिखा है उसमें? क्या आयरन का हाउ मच? more than 75 पे क्या होता है? मेटल लेवल पता क्या होता है? क्या होता है? पढ़ना चाहिए. दैट इज व्हाई वी गिव इट. हम तो सही क्या है? फेरेटिन से क्या होता है? ओके. लेस देन 50 पे यू हैव टू स्टार्ट. एनीमिया इज वन ऑफ द प्रेगनेंसी. सब लोगों ने कैप्लान को लिखा है और आप कैप्लान खोल के देखो इंफॉर्मेशन कैप्लान के बारे में जो आपके रेफरेंसेस है उससे बता सकता हूँ. आपकी सब कॉपी पेस्ट करना जरूरी नहीं. कैप्लान में इतना लिखा है दैट इज सफिशिएंट. ओके. मेक 3 slides and if you want to read something up, your source should be academic. कोई आर्टिकल है, कोई बुक है, just read from that. That is for your future also. You start treating a patient like this when you will. Okay, from textbooks it is easily available. So if you know RLSK, for example, RLSK you presented diagnostic criteria. Okay, restlessness, more diurnal variation. Okay, improves interest and say present for 3 times in a week for 3. Diagnosis done. Then you rule out other things. You get roperidol or roperidol or pramipexole and iron therapy. For your level, that is more than sufficient. Okay, no need to add extra. All right. Also, if you in treatment also, if you are like MBBS, so you will have to go into specialties which are not a main specialty. Research is thing. No need to add extra things. PPT download कर दे तो कर दो फिर तुमको एक्सप्लेन करना मुश्किल हो जाएगा. Stick to basics. Capital set off is more than sufficient. A pharmacotherapy if you want to go for any specific medication. For example, you want to study Rabanol, go to a pharma. All of yours preparing for need. I'm sure you have pharmacology, physiology books, etc. ठीक moderators for others. वो 3 साइकिल्स जो सेक्सुअल साइकिल है तो कैप्लान में है वो कैप्लान सिनॉप्सिस और कॉम्प्रिहेंसिव सिनॉप्सिस. ठीक है. दैट इज ऑल. यू ऑलरेडी डिड वेल बट नो नीड टू ऐड एक्स्ट्रा टू मेक इट सिंपल information which you can Okay, even in 1 hour in your future also, आप 1 घंटे का presentation भी दोगे ना, उसमें ultimately information 2-3-4 slides की होगी, बस वो effective रखनी चाहिए अपने audience को, ठीक है? बाकी बढ़ाने के लिए तो जितना मर्जी बढ़ाओ, ठीक। मॉडरेटर से भी रेफरेंस अगर लेते हो तो उनको बोलो कि कॉम्प्रिहेंसिव है या साइनॉप्सिस है और कौन सी एडिशन है, एडिशन नोट्स पूछो, प्लीज पूछो, ठीक। एक ग्रुप फोटो अभी जी तो वीआईपी नहीं है। हमारे पास है सर्टिफिकेट है हमारे पास, खत्म हो गए नहीं कर रहा है। ओके, और कुछ है?
यार अब जो भी करती प्रेजेंटेशन की चाहे आपसे तो नीचे हो कुछ नहीं ये अवार्ड्स दिया कोई प्रेजेंटेशन फालतू के आर्टिकल और ये सब कुछ आपको अगर जाता तो जिंदगी कॉपी प्रेजेंट करते हैं आप कुछ नहीं करनी है ड्रग्स के नाम पे एज इट इज जो डिफरेंशियल डायग्नोसिस होती सब कुछ है देखकर पता चल रहा है क्योंकि ये सब कुछ गलत निकल रहा है ये सारा गलत इन्फॉर्मेशन कितना कहीं भी नहीं पता चल रहा है इसको किसने ये पता चल रहा है देखकर